Okay, we're going to talk about shoulder anatomy and some basic shoulder pathology. This is a lecture I give to first year medical students who are entering their anatomy curriculum. So we're going to talk about some bony, cartilaginous, ligamentous, and membranous components of the shoulder, some biomechanics, and then review some common injury patterns as well. So starting with the anatomy, the shoulder is a very complex joint. That sounds right, but of all of the joints, it's probably the most complex because it has to do the most. And so the shoulder joint can include four joints essentially. The complex is primarily the glenohumeral joint and acromioclavicular joint, which you see here. You also have to think about the scapulothoracic joint and the sternoclavicular joint, which I will get to. But those four joints make up the shoulder complex, with the two major joints being seen here. So the glenohumeral joint refers to the articulation of the glenoid rim and the humeral head, which is a ball and socket joint encapsulated with synovial fluid. It is stabilized by a significant number of ligaments, as you can imagine. Some of them are labeled here. You see the superior glenohumeral ligament. If there's a superior one, you can imagine there's more. There's a middle and inferior. There's a transverse humeral ligament. Whole bunch of stuff here that's not pictured. The acromioclavicular joint, better seen on the left side of the screen. The most noteworthy ones are the acromioclavicular joint here. Okay, so acromion, clavicle, acromioclavicular joint, stabilized by the acromioclavicular ligaments, the coracoacromial ligaments, so there's a coracoid process, the coracoclavicular ligaments. So talking more about the AC joint, as we would call it, it is a synovial joint. It has a little tiny articular disc in it. It can have a joint effusion, so you can see swelling there. It is a stabilizing joint for the shoulder, primarily in anterior, posterior, and superior, inferior, and rotational. So the AC ligaments, so the acromioclavicular ligaments, provide resistance to forward, backwards, or anterior, posterior displacement. And then the coracoclavicular ligaments here provide rotational and vertical translation resistance. Okay. So again, the AC acromioclavicular ligaments, CC coracoclavicular ligaments. Those are important, and we'll get to why. Vascular supply, arteries around there, suprascapular, and thoracoacromial. And then Hilton's law is basically that the joints are supplied by articular branches of the muscles around the joint. So here are those nerves: lateral pectoral, suprascapular, and axillary nerve. But a humeral joint, more complicated, right? So let's just walk through the structures that we see here. Getting past the AC joint, we come down here, we see the subacromial bursa, we see the coracohumeral ligament, right? So the coracoid process is attached to the humerus. The transverse humeral ligament here holding down the long head of the biceps tendon. We see the subscapularis tendon here, which has been cut. There's a subscapularis bursa. Okay, and then you see some of the fibrous capsule of the joint, right? And unsurprisingly, the greatest range of motion. Other things that are worth mentioning here, right? Glenoid labrum, right? Cartilaginous rim of the glenoid, which increases the size of the socket, but provides more mobility than a bony rim does. The joint capsule, some of the ligaments, it is a synovial structure, so it has a synovial membrane filled with synovial fluid. There are bursa around it. Here are some additional views. This is a coronal view right here. This is a coronal view of the MRI. And here we get down and we see the synovial membrane in the inferior articular spot. And then we come up, we start to capture the glenoid labrum. Okay, we see the articular cartilage on the humeral head, right? Those are the two things that are interfacing for the most part with the range of motion. We see the synovial membrane coming all the way over here with joint capsule. We see an additional joint cavity here, which is not really well characterized in this coronal plane, but is all contiguous. We see the subacromial bursa here, which is collapsed, which is normal. We come over here, we see all these ligaments on top of the joint, which we have mentioned. And then here in the MRI, more of a real world sort of perspective, acromioclavicular joint, glenohumeral joint, greater tuberosity, neck of the humerus. So the glenohumeral joint, again, here we see a similar picture in the coronal plane. additional findings here now, we see the tendon of the supraspinatus coming under the acromion, okay, which is a vulnerable position for it to be in and why it is often pathologic. What else do we see on here? Okay. Here's a picture of the glenohumeral joint from the sagittal plane, right? So the humeral head is disarticulated, and now we just see what's inside. So we see the glenoid cavity. This is the bony glenoid cavity. The blue part around it is the labrum, again, expanding the size of the cavity, but giving it more flexibility than bone might. We come out farther, we see the fibrous membrane here, okay, which essentially is the outside of the joint capsule. We see the long head of the biceps brachii tendon, which inserts the superior part of the joint. So injuries to the joint or the biceps tendon can affect the other. Okay, what else do we see here? We see the subscapularis tendon coming in anteriorly. On the posterior side, we're going to see the infraspinatus and teres minor, and superiorly the supraspinatus, right? So we see the rotator cuff muscles coming in around here. We see the long head of the triceps, which would be on the posterior surface of the humerus. We see the latissimus coming in. We see the pectoralis coming in, right? Those are going to fit over the bicipital groove. We see teres major coming along as well. So this is a great picture of the humeral head. And then we see the deltoid up here, which wraps over all of that, okay? Blood supply are the circumflex humeral arteries, innervation, subscapular nerve, suprascapular nerve, axillary nerve, lateral pectoral nerve. Okay, movements, right? So this does a lot. So it's easier to think about things in planes in isolation. However, in the real world, when you're throwing a baseball, you're doing almost all of these at once. But flexion and extension is one plane, right? That's happening in the sagittal plane. Abduction and adduction happens in the coronal plane. And medial and lateral rotation happens in a vertically oriented cranial caudal plane. So I mentioned that I would bring these up. This is the scapulothoracic joint, right? So essentially it does articulate with the thorax, right? It is not thought of a joint in the traditional sense, but if you have dysfunction of the scapulothoracic joint, which can happen for a variety of reasons, such as a winged scapula, scapulothoracic bursitis, scapular dyskinesis, right? That can affect the mobility of the shoulder and the function of the shoulder, right? Over here, we see the sternoclavicular joint, okay, which is just worth pointing out. I'm not going to spend much time on it. It generally is more of a thoracic problem, but if you have an injury to the sternoclavicular joint chronically, it can affect the function of the shoulder. And one thing I just want to mention is Kerr's sign, which is a visceral problem presenting as shoulder pain. And I will just give an anecdote as to what this presents as, and it can really burn you, so you just have to be cognizant of it. I had a tech from the emergency department who came to my orthopedic clinic and told me she was having posterior shoulder pain around her shoulder blade. She didn't have an injury. She liked to rock climb. Her exam was pretty benign. I really had trouble reproducing her pain. Wasn't quite sure what was wrong, but she had some tenderness around the scapulothoracic bursa and the medial scapular border. And so we got an MRI and it was fine. And then I didn't see her for about 2 weeks. And she came up to me in the emergency department and said she had cholecystitis. She did not have right upper quadrant pain. She did not have nausea, vomiting. She did not have a fever. She just had pain in her shoulder blade and her shoulder. And that's what Kerr's sign is. So that can come from a lot of visceral stuff irritating the diaphragm, the liver, and the gallbladder most famously. Okay, here are the muscles of the shoulder joint, right? So flexion, extension, abduction, adduction, medial rotation, and lateral rotation. And you have to commit these to memory. You can really understand when one of these is pathologic, how it affects the shoulder, how your exam can diagnose the lesion. So for example, subscapularis, right? So if you have a patient with shoulder pain and the only way you can reduce or reproduce their pain is with internal or medial rotation, then they almost certainly have pathology of the subscapularis. There are, of course, synergistic muscles, but this is a good clue because it is the only true medial rotator. And then there are some other things that help hold the articular, the glenohumeral joint together and resist downward dislocation. So let's review some pathology. So a 16-year-old boy presents with right shoulder pain. He's a quarterback for his high school football team. He was tackled, falling onto his left shoulder. He appears very uncomfortable, but he is stable. His left upper extremity exam has limited range of motion due to pain. He's tender over the distal clavicle and acromion with no obvious deformity or palpable fracture. However, his clavicle is slightly displaced superiorly. An X-ray is obtained and viewed here, and we see the clavicle coming from medial to lateral. Here's the acromion. We see the widening space. And so this patient has an AC joint separation or AC joint dislocation. Okay. So starting with the basics, here is a normal PA view of the shoulder. Here's one with some illustration or description, right? So you see the AC joint here, clavicle, the acromion, normal alignment of the AC joint. The implication here is that the corticoclavicular and acromioclavicular ligaments are intact. When someone has an AC joint separation, there's different flavors, which I will show you. This is a type 3. The AC joint ligaments have torn, and in this case, the corticoclavicular ligaments have torn. And essentially, the clavicle is now floating. There's also a very subtle clavicle fracture. It's very small. Think of that as an avulsion injury, probably from the acromioclavicular ligaments. So there's something called the Rockwood classification. You don't need to know that, but it basically breaks down the different types, 1, 2, and 3 on the top being the most famous. Just ignore these. These are very rare and pathologic. So think of type 1 is a sprain. So the ligaments are intact, but they have pain over the AC joint. You get an x-ray, it is normal. You can have a type 1 AC joint injury or sprain where nothing is really torn, maybe some minor tears, but the x-ray is normal. You have a grade 2 where the acromioclavicular ligaments are torn, but the corticoclavicular ligaments are intact. So the clavicle is still articulating. The clavicle is still anchored to the coracoid process. And then in a grade 3, those CC ligaments are torn, and now you have a clavicle that's really being held together by the muscular and other attachments that do not include these ligaments, okay? So we're going to come back to that. A 53-year-old woman presents with shoulder pain after an injury. She did not improve after rest by corticosteroid injection and 3 months of PT. An MRI is obtained, which shows a rotator cuff tear with biceps tendonitis. Which of the following muscles form the rotator cuff? So just skipping down, you're going to say supraspinatus, infraspinatus, teres minor, and subscapularis. So the sits muscles, SITS, and you have to know those. So let's talk about some rotator cuff pathology. Here are some different pictures. Up here you see a partial tear, right? And there are different flavors of tears. Okay, superior, inferior, intersubstance, to name a few. Most people have partial tears. You can have a complete tear, which of course is a problem. You will now have trouble abducting your arm if your supraspinatus is completely torn. On MRI, we see a couple pictures of complete tears, at least in the single view here. So this is a coronal plane, and you can see the supraspinatus. And we know that because here's the glenoid and the humerus, okay? And you see the supraspinatus starting to retract there and not attaching to the greater tuberosity. Here's an even more dramatic one where it is retracted by maybe a centimeter or so. And you can see all this fluid here is a joint effusion, which is of course pathologic from whatever injury this person sustained. You can also see a bone bruise here, it looks like, although you can't tell from this single cut. This x-ray is interesting. What you see here is a high riding humeral head. See how the humerus is almost articulating or touching the inferior margin of the acromion. This is indicative of a chronic rotator cuff tear where the supraspinatus is no longer in between the two bones, resisting this upward displacement, and then you can almost see the vertical displacement of the humeral head here too. So this patient certainly has a complete rotator cuff tear and probably would require surgery if they're in a lot of pain. So let's talk about rotator cuff tears. There's lots of exams. The drop arm test is a good way to evaluate for a complete supraspinatus tear, where you're just bringing the arm up to maximum abduction, maybe 180 degrees, and then having them bring it down slowly. And if the arm falls and they can't control it, that would suggest a tear. Okay, so you have to think about the etiology of the tear. Is it acute? Is it chronic? Was there an injury? Was there a mechanism? Are they young? Are they old? What do they do for work? Right? Are they a 25-year-old laborer? Are they a 75-year-old retired gardener? What other comorbidities do they have that might have set them up for this? What else is going on with their shoulder? Diagnosis is primarily clinical. You can usually figure it out. MRI, of course, confirms it. You can make the diagnosis with ultrasound. It's a little more time consuming and requires a little more skill, and the surgeons don't really care. So if you're going to send them to the surgeon, the MRI is usually the answer there. Most patients will get better with relative rest and activity modification, lots and lots of physical therapy. This is very well studied now because this condition is so common. You can certainly consider a steroid injection as it is much more benign than surgery, although you can imagine a steroid injection does not fix a tear. You can consider PRP and stem cells. That's some modern medicine that's probably going to find a role in managing this, but we're not quite there yet. And then NSAIDs, Tylenol, etc. Surgery is acute tears in young, healthy people. At least you have to consider it. And then chronic refractory tears, although in older people, you don't typically repair the rotator cuff. what happens is those tears, as they become more chronic in nature, meaning weeks to months, the tendon and muscle atrophy and they retract, and it's very hard to put them back together. So chronic patients tend to end up with a shoulder replacement. As opposed to tendonitis or impingement of the rotator cuff, there are different ways to describe that, subacromial bursitis, and I don't want to get into the distinction there, but the empty can test famously tests the supraspinatus, as does the Hawkins test, a couple that you should know. Management is similar, right? There's not a lot that changes here, as a lot of rotator cuff tears come along as a spectrum of rotator cuff injuries or rotator cuff arthropathy, but these patients sometimes require surgery if they're not getting better. Okay, a 40-year-old male presents with right and left arm pain from a basketball game. He says he got in an altercation with another player and felt his arm pop. He states that it is deformed and he is unable to move it in the ED. He is noted to be uncomfortable with the arm, slightly adducted and internally rotated, with supported by the contralateral arm. The shoulder appears squared off and range of motion is deferred. Strength appears intact. However, sensation is decreased over the inferior deltoid. Pulse is intact. Compartments are soft. What do you think this guy has? The answer is anterior dislocation of the humerus. So anterior is the most common by far. We will talk about posterior. I'm not going to comment on inferior. Okay, it's very rare, but anterior is where most of the money is for first-year medical student. So just some terminology: dislocation, complete separation; subluxation, incomplete separation, and that can be acute or chronic. Meaning the shoulder can sublux and pop back in and essentially be articulating normally after that event, or you can have really significant pathology in your shoulder, whether it's laxity of the joint or lots of tears of rotator cuff muscles, whatever it might be, you can sublux recurrently. So here are the views of the shoulder, right? Here's the AP view. Here's the so-called scapular Y, where this is the scapula. Here's the coracoid process coming anteriorly and the acromion coming posteriorly. And then the axillary view, which gets you a good view of the glenohumeral joint. Okay. Here's how the axillary view is obtained. All right. If you're ever confused, just remember that the coracoid process is always in front and the acromion is always in back. Okay. If you're trying to orient. Same thing with the scapular Y. Coracoid process is always in front and the acromion is in back. That kind of comes from the posterior to anterior. Right, and here you see an illustration of what this can look like pathologically. So this would be an anterior glenohumeral dislocation, right? Here's the coracoid process. And then this would be a posterior dislocation. Here's the coracoid process. These patients, the anterior, present with a squared off shoulder, right? The acromion is very prominent right here. This is a very thin, healthy male. Not always this obvious, but when they are healthy or athletic, this is what it looks like. Usually it is a posteriorly directed force at an abducted, externally rotated arm. Imagine a baseball player or a quarterback getting hit while they're trying to throw the football. You can have just general glenohumeral instability. I've seen plenty of patients who pop out with any contact, without any contact at all. Squared off shoulder, loss of here's the deltopectoral groove, which is lost here. Slightly abducted and externally rotated. And very important to do a thorough neurovascular exam, as there is a high morbidity if there is a lesion other than just the joint. Okay. Diagnosis: radiographs are sufficient. Ultrasound can do it if needed in the outpatient setting. MRI is typically obtained to evaluate for other soft tissue lesions, especially if it's recurrent. Here are some images from the ED or from a patient seen in the ED. Right, here's your dislocation. Here it is on scapular Y. There's the glenoid rim and the humeral head. And then here's your post-reduction film here and here. And then what they're showing with this arrow is what's called the Hill-Sachs deformity, which is essentially a compression fracture of the humeral head where it has collided with the glenoid rim during the acute event. So in the ED, we're reducing these. There's a lot of ways to do that. We're immobilizing them to get them comfortable. We sedate them. We do nerve blocks. Sometimes they have to go to surgery if there's fractures or neurovascular injuries. More chronically, you're typically getting an MRI to look for other pathology, PT, and then surgery for a variety of reasons. Certainly recurrence. Axillary nerve, most commonly injured nerve, rotator cuff tears, humeral fractures, Hill-Sachs fractures, right? That's just the humeral head here. But you can also fracture the surgical neck, the anatomic neck, the greater tuberosity can pop off or be plucked off. And then you talk about glenoid lesions, right? So imagine that disarticulation is injuring the glenoid as a bony structure, and then you can also have labral tears as well, which are pretty common. All right, a 16-year-old male is brought in by ambulance following a seizure. EMS states that his mom witnessed a generalized tonic-clonic event lasting about 90 seconds, which terminated spontaneously. The patient has known seizure disorder and states compliance with his Keppra or levetiracetam. He is primarily complaining of left shoulder pain and having trouble moving it. Sorry, that's a little bit redundant. His radiograph is shown to the right. What is the most likely diagnosis? So I will say two things. First off, this is a kid, right? So differential diagnosis is a little bit different when the physis is open. And because you're looking at this x-ray, we don't see an AC joint separation, could be. We don't see a clavicle fracture, although this is not a dedicated clavicle film. And we don't see the humerus laying down here anteriorly like on the other patient. So just by process of elimination, we'll say posterior dislocation of the humerus, although if you're confused here, I will explain to you why. So posterior glenohumeral dislocation, famously missed and difficult to diagnose radiographically. So this is dislocated. You can't tell. They call it a light bulb sign. You see a little bit of widening of the glenohumeral joint. It is subtle. The radiologist will miss it, and a non-orthopedic surgeon will miss it as well. However, other views are very useful, right? So here is your here's your axillary view. Here's the clavicle anteriorly, right? So orient to the clavicle or the coracoid. And then here's your humeral head posteriorly. And then same thing here. Here's your scapular Y view. It's a great picture. Here's your clavicle and coracoid process. And then here's the humeral head sitting behind the glenoid. Okay. So posterior shoulder dislocations. Think of seizures. Think of electrocution. Okay. Think internal rotation, adduction. They are frequently bilateral. Okay. As you can imagine, both seizures and electrocution do not affect one joint in isolation. And then they don't typically, they definitely can. Most important thing is that these are missed. Management is pretty similar to anterior. All right, adhesive capsulitis is exactly what you think it is. It is adhesive and it is inflammation of the capsule. So this is frozen shoulder. It is a pathologic process of scar tissue and adhesions, which leads to pain, stiffness, and dysfunction. Typically idiopathic. At least half of the time, we don't really know, but it's highly associated with prolonged periods of immobilization. So somebody who dislocates their shoulder or has a clavicle fracture who is left in a sling or an immobilizer, or somebody who's post-operative who's left in an immobilizer for too long or for the wrong reason and develop this. Okay, and this can be highly problematic. There are some risk factors like diabetes, hyperlipidemia, hypertension, hypothyroidism, genetic component. It is a clinical diagnosis, okay? The most important part is that it is insidious and painful initially, and then the range of motion comes. So they may just have generalized shoulder pain initially. However, if you cannot externally rotate them and it is very limited compared to the unaffected shoulder, you should be highly suspicious if the clinical context fits. You can make the diagnosis with this is ultrasound of the glenohumeral joint. Here's the probe on the posterior surface. Here is the glenoid rim. Here's the humerus, and then this is the joint. Diagnosis is typically clinical, as I mentioned. Treatment involves physical therapy, corticosteroid injection, which is what I typically do with ultrasound. Getting a needle from the skin to here is not very difficult if you know what to do. You can hydrodilate them, meaning putting a significant volume in the joint to distend the capsule, so you're mechanically stretching the capsule with an injection. And then you can block the suprascapular nerve, which has been shown to help with adhesive capsulitis. Rarely do they need manipulation under anesthesia, and if it's a recurrent problem, sometimes they could do a capsulotomy. Just a few more lesions here. So proximal humerus fractures are very common. They can happen at the anatomic neck, the surgical neck, or along the greater tuberosity, all three, right? They're pretty common. This is usually grandma falling down and landing on her shoulder. You can certainly see them in car accidents. That's typically going to be a younger patient, easily diagnosed radiographically. A good chunk can be managed without surgery, depending on the more comorbidities and age of the patient, but sling with early range of motion for the minimally displaced patients who are not great surgical candidates. However, displaced multi-part fractures or the greater tuberosity, right? So if that pops off, you can imagine how much that might affect shoulder function when everything's done healing if it doesn't heal in the right spot. Here are some examples of this. So this is a glenohumeral fracture dislocation, right? The humeral head is obviously not articulating with the glenoid rim. It is not attached to the surgical neck of the humeral shaft here. That is a surgical problem every day. Here's a multi-part fracture. And then here is a greater tuberosity fracture, and probably all three of these would be surgical. Maybe this one wouldn't if it was grandma. Clavicle fractures are very common. They can be distal 1/3. They can be middle 1/3, which is the vast majority, and rarely they are medial, right? Very hard to diagnose medially with x-ray. Typically falling onto the lateral shoulder. Think of a like a snowboarder or a bicycle, somebody putting their arm out and just landing on the lateral shoulder. Look for skin tending and impending open fracture. You need to do a thorough neurovascular exam. Most of these are non-surgical in a sling with early range of motion. However, if they're open, any neurovascular injuries, polytrauma, floating shoulder, there are like meaning that there's other shoulder injuries besides the clavicle, like a scapular fracture, something like that. And then these do have some risk of malunion or non-union. Some patients do not do well non-surgically. Glenohumeral arthritis, right? We've looked at some x-rays already. I mean, this is just tragic in how bad it is, both of these, right? Imagine you're this patient trying to move your shoulder and how much pain you have. It is associated with a rotator cuff tear. Think of that as a cuff arthropathy. It is insidious, painful shoulder pain without an injury. They may have had a dislocation 30 years ago, but typically this happens over decades. Okay, restricted range of motion. Most patients will be managed non-operatively with medications, therapy, steroid injections, hyaluronic acid injections. However, if these don't work, and I will say these are very bad, both of these patients are going to get a shoulder replacement, okay? If I saw these in my clinic as a non-surgeon, I would inject them once, or I might not even do that, and I would send them straight to the surgeon. I mean, this is just terrible. Final slide, lateral scapular winging here, and then medial scapular winging, right? So we talked about the scapulothoracic joint. The dysfunction here can cause all kinds of biomechanical issues. If it's a lateral winging, you think about the spinal accessory nerve. If it is a medial winging, you think about the long thoracic nerve. Those are board questions that you could be asked.